Welcome, everyone. My name is Kevin Hull, the Director of Education and Chief Business Development Officer at the Chicago Association for Research and Education and Science, known as CARES, the nonprofit corporation serving the Hines VA, Jesse Brown VA, Lovell Federal Healthcare Center, and the Middleton Madison VA. Thank you all for being a part of this. Very excited to present the inaugural presentations of the Hines VA Serwa Research Center on Aging. This program and the awards are made possible from a generous donation from the estate of Mrs. Rose Serwa and the Serwa family, based on their family's service to our country through the military. Very exciting to be here. The director of the Serwa Center, Dr. Holly Kramer, unfortunately cannot be with us today to host. So I'm very pleased to be in her position. She's at clinic and sends her regards and her excitement for the program. We will have 3 sessions. And after each session, we will open up for a question and answer. And at the end of the program, we will have any final questions and answers or discussion before we wrap for this day's program. Thank you all again for being here. I'd now like to introduce Dr. Sandy Kletzel to present her presentation. Thank you.
Hello, everyone. I'm excited to talk to you today about our study, Looking at the Bright Side, advancing our understanding of intrinsically photosensitive retinal ganglion cells in Parkinson's disease. This is one of the first studies funded by the Hines VA Serwa Research Center on Aging. The vision statement of the Hines VA Serwa. For this grant, our study population is veterans.
I am going to stop here 1 second. I think
Talk to you today about our study, Looking at the Bright Side, advancing our understanding of intrinsically photosensitive retinal ganglion cells in Parkinson's disease. This is one of the first studies funded by the Hines VA Serwa Research Center on Aging. The vision statement of the Hines VA Serwa Research Center on Aging is to help establish a sustainable community of providers and researchers at the Hines VA who work collaboratively in focused areas of investigation to expand the understanding of aging and improve the quality of life for older veterans. As I will describe in the coming slides, the overall objective of our Serwa pilot study is to advance the utility of iPRGCs as a biomarker for Parkinson's disease severity and progression, as well as cognitive function. We have put together an outstanding interdisciplinary team to address the study objectives. And we are actively seeking to expand our collaborations with providers and researchers here at the Hines VA, which I do touch upon in the final slides of this presentation. So here I would like to introduce the team of co-investigators. So I'm Sandra Kletzel. I'm an early career investigator in research and rehabilitation development here at the Hines VA. I received my PhD in neuroscience from Loyola University in 2013. I currently have a Career Development Award, a CDA2, with mentorship from Teresa Pape. I also have a Spire Award. Both the CDA2 and the Spire are looking at RCTs to look at different cognitive rehabilitation approaches for veterans with Parkinson's disease and mild cognitive impairment. Dr. Gaines is an optometrist at the Hines VA and a clinical assistant professor and director of the clinical research program in the Department of Ophthalmology at Loyola University Stritch School of Medicine. Dr. Gaines has developed a research track to study the relationship between intrinsically photosensitive retinal ganglion cells, these iPRGCs, and neurological disorders such as Parkinson's disease and Lewy body dementia. He has established a laboratory at the Hines VA for the evaluation of iPRGC function and has successfully validated a clinical protocol for iPRGC analysis in Parkinson's patients. Dr. Coletta is an attending neurology physician at the Hines VA and assistant professor of neurology at Loyola University Medical Center. Dr. Coletta is the director of the VA Parkinson's Disease Movement Disorder Consortium Center and co-chair of the Movement Disorder section at the Hines VA Hospital. Through these roles, Dr. Coletta has a strong interest in developing a research track for Parkinson's disease-related research. Dr. Chawla is the former chief of neurology here at Hines and currently director of both the Autonomic Nervous System Laboratory and Clinical Neurophysiology Laboratory at Hines VA. He is also a professor in the Department of Neurology at Loyola University Medical Center. So unfortunately, I was not able to get a picture of Dr. Scheib, but she is a pulmonary critical care physician and coordinator of the sleep lab at the VA hospital. She's also a board certified sleep physician. Dr. Rachel Ellison is a clinical neuropsychologist and an assistant professor at the Illinois Institute of Technology, IIT, in the Department of Psychology. She completed her postdoctoral training in clinical neuropsychology through the Hines VA Specialty APA accredited postdoctoral fellowship in clinical neuropsychology. Dr. Ellison holds a walk appointment both in research and a mental health service line of the Hines VA. For this grant, our study population is veterans with Parkinson's disease. Over 100,000 U.S. veterans living with Parkinson's disease, or PD, currently receive PD-related care and services from the VA. Parkinson's disease is a multi-system disorder that involves the nigrostriatal system, as well as cognitive, mood and behavior, autonomic control, and sensory processing systems. The four cardinal symptoms of Parkinson's disease are tremor, muscle rigidity, slow movement, and balance disturbances. And as this nice diagram shows here, these four symptoms are just the tip of the iceberg. Under the surface, there are many non-motor symptoms which affect the quality of life. And while we have treatments to help control motor symptoms, effective therapies to control non-motor symptoms are actively being sought after in research. Here's another nice diagram of the timeline of Parkinson's disease. In the middle here, we see the clinical onset, when motor problems can be detected. As the disease progresses over time, motor complications progress. And stages of motor impairment are described as Hoehn-Yahr stage 1 through 5. So the typical presentation of Hoehn-Yahr stage 1 is unilateral tremor, some rigidity, akinesia, with stage 2 progressing to more bilateral symptoms. Stage 3, we see more of the poor balance. Progressing to stage 4, there's severity in all the symptoms, and falling occurs more often. Independent living is affected, and more severe cognitive decline is common. On the flip side, over to the left, we see a prodromal stage of Parkinson's disease. This is before the cardinal motor symptoms of Parkinson's disease can be visually seen or detected. The prodromal stage is thought to start up to 20 years before the clinical symptoms appear. Loss of smell, constipation, sleep and mood problems are just some of the common non-motor prodromal symptoms. Visual processing associated symptoms are some of the non-motor symptoms common in Parkinson's disease. Visual problems are detected in the prodromal stage and can worsen over the course of the disease. Symptoms may span from the primary visual dysfunction, such as decreased visual acuity, decreased contrast sensitivity, and color perception, ranging all the way to higher order dysfunctions, including visual perception, visual memory, and visual hallucinations. There is accumulating evidence that the retina is an important contributor to visual dysfunction in Parkinson's disease. And there's growing interest in retinal pathology, both as an etiological component and as a biomarker of PD-related symptoms. Indeed, the principal dopaminergic neurons in the retina are amacrine cells, which control dark adaptation, color vision, and spatial contrast sensitivity through interactions between the inner and outer plexiform layers. Parkinson's patients exhibit retinal dopaminergic cell loss and the retinal nerve fiber layer thinning. And with regards to cognition, higher order dysfunction in visual processing are known to be an indicator of dementia in Parkinson's disease. So our team is interested in retinal changes in a subset of particular cells in the retina called iPRGCs. The objective of our study is to advance the utility of these iPRGCs as a biomarker for Parkinson's disease severity and progressive, as well as to advance the utility of these iPRGCs as a biomarker for Parkinson's disease-related cognitive function. So intrinsically photosensitive retinal ganglion cells, iPRGCs. We all probably know about rods and cones as photoreceptors found in the eye. Rods provide twilight vision, while cones provide the vision in the day or with bright light. iPRGCs are a third class of photoreceptors found within the retina. iPRGCs are characterized by the expression of a photopigment melanopsin. Rods, cones, and iPRGCs are activated by different wavelengths of light. This is an important feature that helps us measure photoreceptor function, something I'll talk about in a few slides. Now, the role of these melatonin-containing iPRGCs are diverse and range from participating in image-forming vision, such as perception of brightness, to non-image-forming functions, such as the regulation of circadian rhythms, mood regulation, and activation of the pupillary light reflex. Importantly, in terms of Parkinson's disease, melanopsin expression is modulated by dopamine via these amacrine dopamine cells, which project to iPRGCs. Now, in Parkinson's disease, abnormality of dopamine release by photoreceptors is expected to impact iPRGC function. However, the nature of the relationship between loss of retinal dopamine demonstrated in Parkinson's disease and the detriment of iPRGC function is unknown. Here's another nice diagram explaining more about the importance of iPRGCs, light sources, and the effects on sleep and cognition. So the function of iPRGCs is based on the chromophore melanopsin, which is a peak sensitivity at the wavelength of 470 nanometers. So iPRGCs convey light information to many brain regions, including several nuclei implicated in circadian rhythms, including the suprachiasmatic nucleus. The suprachiasmatic nucleus, or the SCN, communicates through the pineal gland, which will secrete melatonin. So sunlight is the most significant source of blue light. Artificial sources of blue light include fluorescent light, compact fluorescent light bulbs, LEDs, flat screen LED televisions, computer monitors, smartphones, and tablet screens. So these sources of blue light, they activate the melanopsin, which triggers a signal from the iPRGCs to the suprachiasmatic nucleus, which tells the pineal gland to suppress release of melatonin. This keeps one in the awake stage, which helps with alertness, memory, attention span, reaction times, learning ability, and overall cognitive performance. Now, in the absence of blue light, at nighttime, while we're sleeping, not looking at our phones or tablets, the pineal gland will secrete melatonin, thus allowing for a better sleep state. So the question is, what happens to sleep quality and performance ability when iPRGCs are not functioning properly or when sleep-wake cycles are disturbed? So how can we measure the function of IPRGCs? Well, importantly, IPRGCs have a unique footprint identifiable in the pupillary response. This provides an accessible modality to evaluate IPRGC function. So as we all know, if we shine a light in our eye, our pupil constricts. We remove that light source and the diameter of the pupil enlarges again. So the data here presented on the right side are figures taken from an article our team published this year. And here, Dr. Gaines measured the persistent pupillary response in patients with Parkinson's disease and a control group. So a key clinical feature of melanopsin-driven IPRGCs is demonstrated by this persistent pupillary response, which is defined as a prolongation of the pupil constriction following extinguishing of the light stimulus during the pupillary light reflex. So in this figure, if we look at the control aggregate data in the middle of the screen, it shows that following the extinction of a 470 nanometers stimulus, which is the peak absorption wavelength for melanopsin, the pupil remains constricted and slowly regains to the baseline form. This recovery process can take about 30 seconds post-light stimulus. This observation, termed the persistent pupillary response, is the basis of the clinical non-invasive invasive assessment of IPRG function. Now, if we look over to the right with the Parkinson's disease patient aggregate data, we see that there is a lack of the persistent pupillary response. So in the absence of ocular comorbidities such as glaucoma, the lack of the persistent pupillary response is an indication of abnormality of IPRGC function. So these data here are part of our foundational work that demonstrates the abnormality of IPRGC function in a cohort of Parkinson's disease subjects. So this was an exploratory pilot study with 17 Parkinson's patients who underwent the pupillometric evaluations. And similar to others, we found that the abnormality of IPRGC response is variable, with a degree of abnormality of a graded nature. So the PD cohort in this work consisted of a mix of Parkinson's disease stages, ranging from Hoehn-Yahr stage 1 to 4. And given that it was a small sample size, we could not adequately assess IPRGC function based on disease duration. Thus, the present study in the Serwa grant, we will address the question of how PD duration impacts IPRGC action. In this slide, I want to briefly address the cognitive problems that can occur with Parkinson's disease. So there are generally 5 cognitive domains described in Parkinson's disease that can be affected. These include attention and working memory, executive function, language, memory, and visual spatial function. So visual spatial function and visual perception processing required for higher order cognitive abilities is particularly affected in Parkinson's disease. And these impairments are linked to cortical dysfunction that can affect perception of space, recognition of line orientation, mental 3D rotation of objects, depth perception, spatial working memory, and detection of motion. These processing deficits are concerning as people living with Parkinson's disease increasingly rely on visual cues to control walking, And daily activities such as walking and driving can really be affected by visual spatial dysfunction. So for my line of research, I'm particularly interested in cognitive changes that occur with Parkinson's disease. So when Dr. Coletta introduced me to Dr. Gaines last year, I was very intrigued with the potential role that IPRGCs may play in cognition for people with Parkinson's disease. As a neuroscientist, I was intrigued by the projections of IPRGCs, which are widespread throughout the brain, including areas controlling sleep and general activity, as well as limbic regions. In particular, IPRGCs have connections to the amygdala, which plays a role in learning and memory, the perihabenular nucleus of the dorsal thalamus, which controls mood, and the pulvinar of the thalamus, which plays a role in sustained attention. So based on this, our team developed the second aim of the Serwa study, which is to explore the contribution of IPRGC function to cognition in Parkinson's disease. So to summarize, the objective of this pilot study is to examine the utility of IPRGCs as a biomarker for Parkinson's disease, both in terms of disease severity and cognitive function. We will address this objective with two aims. First aim is to determine if IPRGC function is differentially affected based on severity of Parkinson's disease. And our second aim is to explore the contribution of IPRGC function to visual spatial and visual perception processing in Parkinson's disease. So our Serwa study is a repeated measures longitudinal pilot study. There will be 3 groups of veteran participants. This includes 2 PD cohorts, which includes 10 veterans with early stage Parkinson's disease. So Hoehn-Yahr stages 1 and 2 within 2 years of their PD diagnosis. A second group is another 10 veterans who are in Hoehn-Yahr stage 3 and who have been 5 to 7 years post their Parkinson's disease diagnosis. And finally, the third group will consist of 10 veterans who are age and gender matched controlled. So study outcomes will be collected at baseline, 6 months, and 12 months. We will conduct standardized neuropsychological testing in person, and there's also a standardized set of self-reports that can either be done over the phone or in person. There will be a standardized in-person eye exam, and we will also be collecting data from the medical records. So notes from neurology, mental health, sleep, radiology, and ophthalmology. Example of variables we'll collect from the medical record includes medication use, comorbidities, data obtained from the autonomic nervous system laboratory. And we're also hoping to analyze stat scans and structural MRI scans from the patients. So this slide here looks at eligibility, inclusion, and exclusion. Dr. Coletta and Dr. Chawla will help with recruitment. And here we've listed the inclusion and exclusion criteria. Screening for eligibility, Dr. Gaines will lead the eye exam, and Dr. Ellison will lead the neuropsychological battery of tests. So while we are waiting on IRB approval to begin our pilot study with the 30 veterans, I do want to take a moment to share what our group has done since being awarded the Serwa grants. So first, our group, along with some other individuals, have submitted an informational educational page, or IEP, for the Journal of Archives of Physical Medicine and Rehabilitation. This IEP is titled A Patient's Guide to Visual Perception Changes That Occur with Parkinson's Disease. In this piece, we describe components of visual perception that may be affected in Parkinson's disease. We provide examples of how a Parkinson's patient may use these components in everyday life, which may help the patient understand why it's important to know about these possible changes in visual perception. We also provide some example questions to ask doctors and therapists on the Parkinson's disease care team. And if a Parkinson's patient is already experiencing some of these visual challenges, we do provide some tips that they can start using to help with their issues. So like I said, this piece is currently under review. I did present this at the ACRM annual conference last month. I am currently the chair of the Parkinson's Disease and Related Disorders Task Force for the Neurodegenerative Disease Networking Group at ACRM. And through this venue, I hope our Hines team can collaborate with other researchers and clinicians around the world to advance this area of retinal function and related cognitive function in people living with Parkinson's disease. And I should note that through this IEP endeavor, I was introduced to Kelsey Waters, an OT here at Hines, who is also a vision rehab specialist. So we are excited to collaborate further with Dr. Waters. At the time we submitted the Serwa application, we were also submitting an application to the Michael J. Fox Foundation. The Fox Foundation grant sought to examine IPRGC abnormality as a prodromal biomarker for Parkinson's disease, with advancing remote patient care technology to complement in-clinic assessments of prodromal Parkinson's disease biomarkers. While this application was not funded, we do plan to continue pursuing this line of research. And this fits with our long-term goal to understand the potential of IPRGCs as a biomarker from the earliest stages of PD, starting in the prodromal stage, leading through the progression of the disease after clinical onset. Finally, I do want to mention that Dr. Gaines pitched an exciting idea just yesterday to the Hines Innovation Program. So the innovation is a spectacle-mounted infrared pupillometer. So the device outlined in this project represents a paradigm shift in how pupillometry and dark adaptation is measured and analyzed in point-of-care outpatient settings. So due to loss of the retinal dopamine in Parkinson's disease, normal dark adaptation processes may be disrupted in Parkinson's disease. So this is what we want to investigate using these spectacles. And since dark adaptation impacts IPRGC function, we want to assess the correlation between dark adaptation and IPRGC function, which will be used as an indicator of retinal health. So our team, with Dr. Gaines in particular, is working with Victor Rivera, a rehabilitation engineer here at the Hines VA. So along the way, we have developed another collaboration with a Hines VA clinician. I'll conclude here with a slide that reviews the study objectives, implications, and future research, as well as the email addresses of co-investigators on the team. Please feel free to reach out to us if you have any questions or are interested in any collaborations. Thank you for your time.
Thank you, Dr. Klessel. Well done. So let's open it up. Are there any questions from our colleagues here or other such comments? You need to raise your hand. Go ahead, Sandy.
I also wanted to note that about 5 minutes before this presentation started, we found out that we were awarded the innovation grants. So we're gonna build those spectacles and we're gonna use it within the Serwa grant to collect data.
Well done. That's excellent. Congratulations. And the cause for collaborations, it just seems like such an opportunity for you and your team to meet all of these other folks within the system. That seems to be such a legacy now of what the Serwa support can promote. That's very exciting. Thank you for your time in preparing and presenting all of that. Okay, so now we're going to move on to our second team of awardees, and that will be Seema and Julia. Thank you for being here, and thanks for your time preparing your presentations.
Thank you, Kevin. I'm going to share my screen.
And just for the sake, I can track any questions in the chat. If you send them just to me, then I can present them at the end of each of these segments for response and question.
Can everybody see my slides okay?
Not yet. It's coming up. There we go. You got it.
Wonderful. Can you still see my slides okay?
Yep.
Oh, wonderful. Thank you for inviting us to present our recently funded research proposal. Our project is entitled Optimizing Veteran Video Connect Capacity to Engage High-Risk Veterans with Advanced Kidney Disease in Goals of Care Conversations. My name is Dr. Seema Lemay. I'm the Director of Hospice and Palliative Medicine here at Hines VA, and I'm going to let my co-PI, Dr. Julia Schneider, introduce herself.
Hi, my name is Julia Schneider. I'm one of the nephrologists here at Hines VA, Associate Professor in Nephrology and Medicine here. Happy to join our team to do this research project. Thank you for having us.
Thanks, Julia. As you can see, we have an entire team behind this project, and it's been really exciting for me, primarily as a clinician educator, to get involved in the research world and really collaborate with researchers such as Dr. Stroop, who has Cinch, Dr. Markosian, and Dr. Balbele, who have expertise in qualitative research, and to work with a project coordinator, Kara Ray, as well as our palliative care coordinator, Alexi Valkamp. As a geriatrician and palliative care specialist, I am keenly aware that medical research often ignores our most vulnerable populations. The older adult population with advanced chronic illness, such as chronic kidney disease, has high healthcare utilization. And based on our prior quality improvement initiatives, often has limited documentation of preferences for life-sustaining treatments. Another neat part of our collaboration is considering that this is a multi-specialty perspective. And it's nephrology, working with palliative care and geriatrics. We're also looking to see how technology might be integrated in providing this vulnerable population with high quality, accessible healthcare. At Hines VA, our palliative care team was contacted by the nephrology section to look at healthcare utilization rates and LST, or life-sustaining treatment preferences, of patients on dialysis back in 2020. We discovered through a quality improvement initiative that nearly 3 out of 5 dialysis patients were hospitalized in 2019. Of those who were hospitalized, 1 out of 3 patients were hospitalized more than once. Nearly half of the hospitalized patients ended up in the intensive care unit, and nearly 1/3 of them had rapid response team members contacted to see them, meaning they had an acute event during their hospitalization. In addition to these statistics, we discovered that 3/4 of the patients on hemodialysis, which is a life-sustaining treatment, did not have life-sustaining treatment notes written. We embarked on a quality improvement initiative with partnering with nephrology, and by engaging veterans on dialysis in goals of care conversations, our palliative care team helped raise the rates from 27% of those patients having LST notes to 81%. Now I will turn the talk over to Dr. Schneider to discuss the significance of advanced chronic kidney disease in the older veteran population. Oh, actually, first I'm going to talk about the LST initiative. Sorry about that, Julia. I'd be remiss not to describe this major national initiative that was a huge impetus behind this research project. In 2018, the National Center for Ethics rolled out the LSTDI, which is the Life Sustaining Treatment Decisions Initiative. It was a national initiative to proactively engage patients with serious illness in goals of care conversations to clarify their life-sustaining treatment preferences. Since 2018, an expectation is that all high-risk veterans, including patients with advanced chronic kidney disease, should have documented LST progress notes and orders within a specific time frame while under VA care. In addition, we know that goals of care conversations can be completed via telehealth. And so looking at these two issues, the LST note and thinking about goals of care conversations, I'm going to turn over the conversation to Dr. Schneider.
Thank you so much, Dr. Seema. So I would like to start out by talking about chronic kidney disease. Chronic kidney disease is defined as abnormalities in kidney structure or function present for over 3 months. It affects an extraordinarily high number of people in the United States. 1 in 7 adults in the United States has chronic kidney disease. That amounts to 15% of US adults or 37 million people. Chronic kidney disease is divided into 5 stages. Stages 4 through 5 are considered the more severe or more advanced stages. And usually in stages 4 through 5 is when patients or veterans in our case need to prepare for dialysis or transplant if they qualify. Stages 4 through 5 are very difficult stages, very complicated. Patients have high risk of hospitalizations, rehospitalization, accumulation of comorbid conditions, and frailty. Next slide. Chronic kidney disease disproportionately affects elderly patient population. Here you have a slide from Advances in Chronic Kidney Disease showing that ages 65 and older carry the burden of chronic kidney disease. In the VA, the Veteran Administration data estimates that 25 to 30% of veterans aged 70 and older are affected by chronic kidney disease, stages 3 through 5. Patients with advanced chronic kidney disease suffer from high mortality rates. Even when adjusted for age, the USRDS data shows that patients with chronic kidney disease stage 4 through 5, age 65 and older, are at double the risk of death than the younger patients. In advanced stages of chronic kidney disease, patients must prepare for treatment of kidney failure. Usually that means they have to prepare for dialysis or transplant. Preparations for dialysis includes choosing a dialysis modality. That may be at home dialysis or in the center dialysis. obtaining a surgical dialysis access for either modality, identifying a support person or resources that will be required to transport and travel patients to and from dialysis, determine if dialysis can be done for a patient while he continues to live at home, or should a move to a skilled nursing facility be done. And finally, for some, patients need to patients need to consider conservative kidney management, which is without dialysis. Dialysis is very difficult. Mortality in the first year of dialysis in patients 75 and older approaches 40%. Even those with better prognosis face multiple hospitalizations and declining functional status. In the last month of life, patients on dialysis over 65 and older must face higher rates of hospitalizations, intensive care unit admissions, multiple procedures, and death in the hospital. This is more than patients with cancer or heart failure, while using less hospice services. When listening to the voices of our patients, we find that 65% of patients on dialysis would prefer to die at home or in hospice. And more than half would choose care focused on relieving pain and discomfort rather than prolonging life. As a result, the Renal Physician Association provided guidance on serious illness conversation. This is also known as goals of care conversations. The Renal Physician Association recommends that goals of care conversations should be conducted in all patients with advanced kidney disease who are considering whether to choose dialysis. Patients' healthcare proxies should be included in such conversations. Such conversation will initiate a shared decision-making process. A shared decision-making process in a relationship is particularly important for patients with stages 4 through 5 chronic kidney disease. American Society of Nephrology put together Quality Patient Safety Task Force. This was charged with raising awareness of quality and patient safety issues and promoting high-quality care for all patients with kidney disease. And this led to ASN's Choosing Wisely campaign, which concluded that we should not initiate chronic dialysis without ensuring a shared decision-making process among patients, their families, and their physicians. As such, goals of care conversations will increase chance of dying of our patients in their preferred setting, usually at home, reduce hospitalizations, lead to less aggressive care, improve caregiver experience, and lead to less anxiety and stress in patients. We know that 90% of patients on dialysis want to have such conversations, but less than 10% report doing so, and less than 50% of patients complete an advanced directive. Barriers to successful goals of care conversations are multiple, and some are included on this slide. Lack of patient understanding of their disease prognosis. Inadequate clinical training in conducting goals of care conversation is a big issue. It promotes anxiety, hesitance, and avoidance of such conversations altogether among clinicians. Healthcare-driven focus on intervention and procedures. Documentation, which is broken and disconnected among multiple EMRs. And finally, lack of metrics for serious conversations. To overcome such barriers, more research is needed. It's needed to learn how to hold goals of care conversations for elderly veterans with advanced chronic kidney disease. More research is needed in identifying the framework to evaluate readiness and to engage in goals of care conversations or the outcomes in elderly veterans. And more research is needed in determining visit modality to hold goals of care conversations in the context of pandemic and high degree of disability or homebound status in geriatric veteran population. With that, I turn over my talk to Dr. LeMay, who will outline for you the aims of our current and future research as it attempts to determine role and direction of goals of care conversations in chronic kidney disease veteran geriatric population. Thank you.
Mayor. The VA was an early adopter of technology to expand veteran access to care. Telemedicine has become an important performance measure within the VA, including within the National VA Hospice and Palliative Care Program Office. Video telehealth, or VVC as I'll refer to it, is a cost-effective alternative to standard in-person care with high rates of veteran satisfaction. Current research investigating VVC use in older adults is varied though. Some studies of older adults with VVC utilization demonstrate high rates of acceptability, and VVC has even been used to complete some advanced care planning, or ACP, in geriatric populations. However, other studies have concluded that patients are less likely to prefer VVC if they are older and those with chronic conditions. So really the results are mixed. And although telemedicine has been used for veterans with chronic kidney disease to manage that illness, to our knowledge, our research has specifically investigate the use of the VVC modality for goals of care conversations in older veterans with chronic kidney disease is the first. The aim of our study is to better understand whether VVC is an acceptable approach to conducting goals of care conversations with older adults with advanced chronic kidney disease. Specifically, what are the patient characteristics of those veterans who are willing to engage in goals of care conversations via VVC? How are those patients different than those who elect for in-person or phone visits? Our second aim is to compare outcomes of the goals of care conversations amongst all types of visit, VVC, in-person, and telephone. Finally, we'll use qualitative interviews to interview both patients and our palliative care providers to understand what worked and what didn't work when conducting goals of care conversations via VVC. This will be a multi-method study that is a prospective observational design for the first two aims, and we will use semi-structured interviews with providers and patients to address the third aim. As I mentioned at the beginning of this presentation, older adults are often left out of medical research. So, despite the rising older adult population in the US, we do not fully understand their particular healthcare needs. Our team finds this to be exciting work, to be a stepping stone for future potential studies. Specifically, if we can use VVC for older adults effectively, we may be able to broaden access to healthcare for the vulnerable population. Furthermore, an understanding of how goals of care conversations in this broad group of chronically ill patients may help us better understand their healthcare utilization rates, the decisions that they make about life-sustaining treatments, how this impacts and this may impact financial implications for the VA, and how this impacts patient quality of life based on the decisions they make. Thank you very much for your time.
Thank you both. So are there any questions from our colleagues who are here today?
This is Dr. Adams. I just have a comment and an observation that this study is really a great example of taking a well-known clinical fact. Dialysis patients have high rates of morbidity and mortality. Using a quality project to identify the paucity of important goals of care and an intervention to improve it. And then with the help of the Serwa Foundation, of which one of the reasons this was founded, allowing the clinical folks to collaborate with the research-focused individuals to turn that into a deeper investigation of a really important clinical question, looking at technology, looking at how to make this easier for patients, and in a really systematic way studying it. So this is a great example of clinical research collaboration and the Serwa Foundation being able to assist with a little bit of funding to help move this forward.
Thanks, Dr. Adams.
Thanks, Dr. Adams. We're just appreciative and excited for the ability to really create this network with primary researchers to help move along our.
Yeah. So the dialysis patients spend so much time at the hospital, and that one more trip is a huge burden for them, way more than it may be for another population. So if this proves to be successful, this could be a really, this could be a very important question to be answered.
If I may, the new director of education, the chief of education from Jesse Brown, is Shuba Aya, and she runs all the dialysis at that location. Now that she's a part of the CARES board, I've gotten to know her. We did a clinical trial with her patients. I really appreciate all of your attention on this issue because it's so important. Thank you, Dr. Adams, for those comments. So if we're ready, then we'll go to Dr. Wadwa for our third presentation of 3 here this afternoon.
Thank you, Kevin. Are you guys able to see my screen?
Yes, it may include your notes, just so you know. Right now, it looks like the notes will be included.
Yeah, it seems like it's showing the next slide. So let me just take away the presenter view and change it. Just give me 1 second. Unless Kevin, you can help me with the slides a little bit.
Yes, give me about 10 seconds here. So I will have the screen up. If you give me a second here, I will do it. Okay, hopefully everybody sees.
Thank you, Kevin.
Okay, here we go.
Thank you, everyone, for this opportunity for us to present the work that we are planning to do. And actually, Dr. Schneider and Dr. LeMay's presentation is a very nice segue to what we will be talking in the next few minutes about improving frailty in veteran hemodialysis population. I'm Anu Wadhwa. I'm one of the nephrologists here and the director for the dialysis unit. The co-PI with me on this study is Dr. Manpreet Samra. She's the director for the transplant program. She's not able to join us today. But some background about why this work is so important. We know that over 45 million veterans are of the age 75 and older. So there is a very, very important need for promoting healthier aging in these veteran population. And, you know, we have to direct either the existing resources that we have, or we may have to develop interventions for these veterans who need them the most. Now, a lot of times we consider age as a surrogate risk factor for health. But in all honesty, if you look at it,
There are other comorbidities. If we combine it with age, then that creates a much higher risk for adverse health events, which results to and leads to frailty. So frailty, in itself is a clinical syndrome which is manifested by a decline in health and functional status, which results in increase in an individual's ability and vulnerability to becoming more dependent. And aging and chronic disease, they contribute to the frailty through different mechanisms, which, not all have been studied, but it does include some mechanisms, including oxidative stress, inflammation, reduction in anabolic hormones, and a lot of these can be seen in the dialysis patients. So how are we actually planning to look at frailty? Now, frailty is more of a diagnosis where, it's based on 3 or more of the clinical criteria. Previous slide, Kevin, please.
Sorry.
So that's okay. So, we look at the weakness, which we measure. So these are the criteria that we use to measure using a Freed's frailty score. And I'm going to go over that in a little bit in the later part of the presentation too. But in general, these are not new to us when we see these: weakness, slowing of the walking speed, low level of physical activity, fatigue and exhaustion, and unintentional weight loss. All of these we see fairly commonly in our dialysis patient population. So if we take a look at, the prevalence of frailty in veteran population, then this is one of the studies which has looked at it. This is a retrospective study which looked at more than 2.8 million veterans over the age of 65. These patients were followed for about a 10-year period from 2002 to 2012. And they created a frailty index looking at 31 age-related health deficits. And what they found was that frailty in this veteran population was somewhere around 30% in 2002 and increased to 47% in 2012. So frailty affects roughly 3 out of every 10 veterans. And if we take a look at the relationship between the frailty index, the higher the frailty index is, we look at it going from 0.1 to 0.2 to 0.3 here. And we look at the relative risk of death. Right at a frailty index of 0.2, the relative risk of death increases, and it continues to increase with mild to moderate to severely frail patients. So similarly, if we were to, in the same population, if we were to look at survival time in years, the 10 years follow-up, and then the 2 more years they followed the patients through to 2014, looking at females and in male veteran population, the survival probability, again with frailty score, frailty index of greater than 0.04, clearly we see that frailty was strongly associated with survival or lower survival in patients with higher frailty index, both in the female and the male veteran population. Now, if we were to see, and Dr. Schneider pointed out a little bit, so we have about 13,000 veterans with kidney failure who transition to dialysis each year. And in terms of prevalent veteran hemodialysis patients, there's more than 100,000 prevalent hemodialysis veteran patients. So, if we look at the prevalence of frailty in the dialysis population, these numbers are fairly high. This is a meta-analysis of 7 studies which looked at incident and prevalent hemodialysis patients. And what we can see is the frailty prevalence ranges anywhere from 25 to roughly 75% in the dialysis population. Now, if we were to look at the meta-analysis of the 8 studies that reported initially the unadjusted hazard ratio for association of frailty with all-cause mortality, we clearly see that frailty is associated with 2.28 fold greater risk of overall mortality in the unadjusted population. And even if the multivariate analysis, where we look at the adjusted population, adjusted for age and other comorbid factors, frailty still remains, increases the risk for all-cause mortality by about 1.9 fold. Now, this is one of the studies, so not only is it highly prevalent in veteran population, not only does it increase, it is highly prevalent in dialysis population, not only does it increase mortality, it has a lot of implications on morbidity. And, one of the morbidities that we see is with frailty is a higher risk of falls in the dialysis population. This was a longitudinal study that looked at about 100 patients who were undergoing hemodialysis. 28% of these patients were intermediate frail, and 46% of them were actually frail, severely frail. And the prevalence of, they saw about 30% of the patients, so 1 in 3 patients had a fall during a short follow-up of less than a year. So, frail patients undergoing hemodialysis, they experience 3 times as many falls as their non-frail counterparts. So frailty is a strong independent predictor for falls in hemodialysis patients, irrespective of age. Now, one of the very important things for dialysis patients is their dialysis access, which is their vascular access, which is their lifeline. Now, this is a study out of Taiwan, which looked at 50 patients who were on dialysis. And these patients had either fistulas or grafts as their access. These patients were followed for about 15 months or so, give or take few months. And they saw that almost 35 to 37% of these patients developed vascular access failure. And when they looked at VA, here stands actually for vascular access failure free probability. And when you look at, patients who did not have frailty versus those who did have frailty, so clearly the failure-free probability is much lower in the patients who were frail. So much higher risk for losing the vascular access in frail population. Now, another very important question that comes up is quality of life in these dialysis patients. We have heard very recently, how they come 3 times a week for dialysis and everything else, and they are connected to the machines for so many hours that their physical activity is clearly impacted with all the travel, with all the, connection to the machine to get their treatments. So what kind of quality of life, do we see in these patients? So this was a prospective longitudinal study which looked at health-related quality of life in about 230 dialysis patients. They assessed that on 2 occasions. One at the time, this was from a transplant center where the patients came for listing for transplant. So they assessed their health-related quality of life, and then they assessed it again at another point in time when the patient actually came for the transplant. And what they found was that the patients who were actually frail, they had, at all ages were more likely to report fair or poor health-related quality of life, both in the beginning and at the follow-up. So here, when we look at the bars in the frail patients, poor to fair, the darker color at the bottom, this percent is much higher in the frail population compared to the non-frail population. Now, this frailty does have very strong implications, again, not in all, just in all the aspects that we just talked about and covered in terms of just prevalence, mortality, falls. There's even data on hospitalizations, vascular access, and then quality of life. This also becomes an issue for patients on dialysis when it comes to their treatment options. So in terms of how do these frail people do with the kidney transplant evaluation, this is a study from 3 centers over 10 years where 7,000 kidney transplant patients were evaluated. They used the frailty score, which is what we touched upon in the beginning and the one that we are using for our study. And what they found was that for patients with frailty, their possibility of, compared to the non-frail patients, almost half of these patients are less likely to be listed compared to the non-frail patients. And, frail patients will get transplanted 32% less frequently than the non-frail patients. So significant implications for our dialysis patients in terms of access to care and several other parameters for their health. So that's why frailty is something very, very important aspect for the dialysis patients. Now, despite all these strong clinical outcome implications that we talked about, and some of the aspects of it may be partially reversible, why is it that the frailty assessment is not routinely done in dialysis patients? So it's not been implemented in routine care with kidney failure patients or in patients even going for kidney transplant. So there are several barriers to it. We'll touch upon some of this. Now, one of the main reasons for that is, while there still have been assessments that are being done periodically on and off, but the efficacy, there's not good interventions. And when there are interventions, the efficacy of these interventions to improve frailty, they have not been successfully or established in a very clear-cut manner. So these interventions have not really targeted frail patients on dialysis. So that brings up a lot of confusion if we don't know about effectiveness of something. Maybe that's the reason this cannot be even implemented as a routine part of assessment. Now, in addition, when we look at those interventions, what specific components of those interventions will truly have some efficacy in terms of improving the frailty? So that's another question. So that brings us to our study on the next slide is, so our study is designed around these unanswered questions, and we are very thankful to Serwa grant for this funding opportunity to be able to do this study at Hines as part of it. And one of the big strengths of our study is that the study aligns with the VA's eye care values of integrity, where we adhere to the highest professional standards in doing the study, to our commitment to serving our veterans, to be advocates of our veteran, as the name of our study title right here says, the feasibility of designing a veteran-centric physical activity intervention in frail veterans on hemodialysis. So we really want to advocate for our veterans with this veteran-centric study, and we want to provide them with the highest quality of care, as is the excellence part of our eye care values. Now, that takes us, with that background, coming into the specific aims of our study. We want to examine the feasibility of assessing frailty among renal failure patients receiving dialysis at Hines VA Hospital. Our second aim of the study is to design a veteran-centric physical activity intervention, again targeting frailty reduction among veterans on hemodialysis. And third aim, specific aim for our study is to assess the feasibility of implementing this intervention in a pilot sample of veteran patients on hemodialysis. So we will be using the frailty scoring system for that. This has been validated in dialysis patients as a measure of frailty. It mostly looks at 5 main characteristics, which is an unintentional weight loss of about 10 pounds in a patient over a year, weakness, which we measure with the dynamometer with the hand grip strength, So there are some parameters for that. Exhaustion, which is, again, self-reported, and it has to be at least 3 days of the week. So we have a whole set of a scoring system, which, we have gotten access through Johns Hopkins, which has this frailty score implemented in there. And slowness, which is the time taken to traverse 15 feet or 4.5 meters on a known route. And then some criteria for low activity, which are assessed by asking certain questions to make that assessment. Now, based on these characteristics, the patient may be able to score certain points. And if they score 3 or more points for these criteria, then they fit into the frailty phenotype. And if they score 1 or 2 criteria that are present, then it fits into the intermediate or the pre-frail category. So in terms of dwelling a little bit into more detail about our AIM-1, where we will be offering this study to all dialysis patients over the age of 50. Patients will be approached during their regular hemodialysis session. We do have some exclusion criteria where if there has been a cardiovascular event, because we have an intervention phase also for these patients. So we would be excluding some of those patients, those with advanced dementia or paraplegia who are unable to do the walking, and some very, major cardiovascular events if they have happened in the last 3 months that we are unable to assess the frailty in these patients. In terms of outcomes for this AIM for our study, we would be looking at the proportion of patients with documented frailty in the medical records. We will be looking at % of patients who were successfully evaluated for frailty from the eligible patients. Average duration it takes to measure, because some of these may be the reasons or barriers why frailty assessment has not really been implemented as a routine assessment in dialysis patients. And then describe the frailty distribution amongst our own veterans at Hines VA Hospital. Coming to the specific AIM 2 and 3, the two kind of blend together a little bit. Here, eligible veterans who meet a frailty score of 3 or more, we will invite them to participate in the AIM 2. What we will be doing, this will be in 2 phases that we will do this. So phase 1 will be a prototype development phase where we will have 5 veterans participate over a 2-week period to develop a prototype of a possible intervention. Now, out of these 2 weeks, 1 week will be in clinic where then the patients come for their dialysis treatment either before or after their treatment. We will have an exercise physiologist work with them to train them about the intervention. And then the second week will be, again, we will be using the teletechnology where we would give them some feedback in the clinic for the day they come once. And then the rest of the prototype, they implement it at home. And we make assessments in terms of, how they did with focus groups, and also make some assessments of their perceptions, preferences. So the focus groups would be very, very helpful in understanding our veterans' perceptions, attitudes, beliefs about, frailty, physical activity. So we will be doing that at the beginning before we develop the prototype. Then based on their feedback during that focus groups, we will be developing this veteran-centric intervention. And then we will do another focus group session at the end of the 2 weeks to understand again their perspectives about what they thought about this 2-week prototype. Now, once we have this prototype developed, and it does seem like we are being very ambitious in using this grant and trying to achieve quite a bit as part of the study. But in the phase 2, the prototype that was developed, we would want to do it as a pilot where week 1 will be now stretched to 6 weeks of intervention, and week 2 of in-clinic at home will be the next 6 weeks. So total of 12 weeks where we would implement this prototype of activity, which would be developed specifically by our exercise physiologist. And again, with this, we will do focus groups at the beginning because this will be a different set of 7 veterans that we will have. We will do it at 6 weeks, and then we will do it at a 12-week mark. Again, there's not much data out there about patients' perspective on these activities, and not specifically like we are not doing cardio with the patients, but coming up with their perspectives about activity, coming up with their perspective about this intervention, because those have been some of the barriers that have been seen where patients are not interested in participating. So our goal is to try to do this. And as Dr. Elaine Adams was alluding to, that, even to come one additional day for these patients means a lot because they are here half of their week with us. So our goal is to incorporate this either before or after their dialysis session. Now, in terms of outcomes, we will be looking at the acceptability rates, patients who agreed and consented to participate, and then the fidelity in terms of % of patients who completed the program, and attendance at the lab sessions and for home exercises. So what we are really trying to do with the study, is to maybe see if at some point in time we can develop a frailty assessment clinic, either within the dialysis unit or within our transplant center, which will routinely provide frailty assessment. Now, frailty assessment is really becoming big in surgical world, and from the, being dialysis providers, we really have to become more and more cognizant because our patients can be declined from surgery and other reasons, because now the surgeons are going to start assessing frailty. Kidney transplant centers are going to start to do some assessments about frailty. And if we are not on top of things or ahead, in looking at this, our patients can be denied care. And that's something we really want to work on to not let that happen. So our goal will be to create a FIT program, as we would call it. Again, very ambitious at this point in time, but we really see this, a very important tool to assess the frailty in our patients, look at the ways to improve it, have a frailty intervention program, have a frailty assessment clinic. Now, has this been done successfully? So and then of course we will have to look at what we are doing as a pilot in a larger setting, as a bigger clinical trial to look at all of this. So that takes me to my next slide, where I want to say that we have such a great team that has come together to look at this frailty in dialysis patients. Dr. Megan Sheets, she is actually a pioneer in the field of frailty, specifically as it relates to dialysis patients or kidney transplant patients. She's a geriatrician at University of Chicago, and she actually started frailty clinics in University of Chicago. So there is a prototype in the private sector that has been developed and has been used, and we are looking at their referral patterns for patients who are being referred, dialysis patients who are being referred. So she is a great resource for us as part of the study because we don't have something similar yet in the VA system. And so she will serve as a consultant for our study. Dr. Marcosian Talar has been very instrumental already, and she's been helping with multiple aspects of the study. She'll be doing the focus group, qualitative analysis, and also will help with the dissemination of the data and with the planning and analysis part. Another very, very strong and very exciting part of our study, again, our multidisciplinary team. We are working with Christine Jelinek. She's an exercise physiologist with over 24 years of experience. She's working on multiple research studies at Hines in subjects with chronic medical conditions. She's very excited to work with us with dialysis patients. A lot of her work has been with pulmonary patients before. And she's been very instrumental because she will be helping us in assessing the frailty in these patients and then designing the intervention, both the prototype and the actual intervention phase. Dr. Gorbian, he's the Associate Chief of Staff for Geriatrics and Extended Care. His wealth of knowledge from the geriatric standpoint and feedback would be very instrumental for us. Dr. Kevin Stroop, again, no stranger to any of us here. He is the acting director for the CINCH, the Center for Innovation for Complex Chronic Care, which is a health services research center at Hines VA. And, he has substantial experience as a PI co-investigator of VA-funded merit review grants, much larger grants. So he will be providing us guidance in overall conduct of the study. Dr. Balvale will be helping with the planning and conducting of the analysis part. And Dawn really will help us. She's a project coordinator. She's helping with day-to-day activities of the study and ensuring that, we are running the study in a timely manner with a laid out timeline and also with the IRB. So with that, we are very, very excited with the strengths of our study, which aligns with the iCare VA mission of providing care to the veterans, and with the Serwa grant, which wants to bring together a multidisciplinary team of clinicians and research scientists to work collaboratively to improve the quality of life for, in our case, for our eligible kidney transplant patients, older veterans on dialysis, and potentially improve their surgical and overall outcomes. With that, I'll be happy to take any questions.
Well done. Thank you. I have a question, maybe just on a broader sense. From your mentor and trainee exposure, are there physicians pursuing gerontology, geriatrics, GREC, the whole deal, with Madison having that GREC site? I've been very intrigued as to how is it at the newly minted physician set, are they pursuing geriatric and aging related care? And that could be for everybody. And we can stop the recording if that's better. But as the only layperson I think on the call, I have a juris doctor, not a medical doctor, but that's, the actuarial tables are obviously clear as to how many people are in that aging category. Are the medical trainees pursuing careers in this field?
I can speak as a geriatrician. It is traditionally an unpopular field that actually lowers your income despite doing more training. And that being said, we have a geriatric fellowship here at Hines and Monola, and our geriatric fellowship director is amazing, Dr. Bial. She actually has been able to recruit 7 geriatric fellows for this academic year. So we currently have 7 geriatric fellows. It's probably one of the largest programs in the country.
Wow.
Our numbers fluctuate widely. I think with the pandemic, it's increased the number of people interested in going into fellowships and maybe delaying,
Yeah.
the workforce out there, looks like job opportunities that were during the pandemic. That may have kind of pushed people to go into fellowships, but traditionally, quite an unpopular fellowship for people who really care about working with older adults.
Could be, sorry, go ahead.
I had a question for Dr. Wadlow, a couple of good questions. This is such an interesting, take on thinking about frailty, which is something like as a geriatrician, I hold near and dear to my heart. And actually, Dr. Heisencheeks was one of my fellows when I was at University of Chicago, and she is just a phenomenal person to work with, just a very professional researcher and clinician. So I was wondering, you talked about frailty in the setting of end-stage renal disease on dialysis patients and their risk of falls. And I was wondering, and quality of life being quite poor. Did you find anything in the literature, or might it be interesting in the future to compare the veterans that end up choosing conservative care instead of going towards dialysis, and those conservative care patients, how do they rate their quality of life compared to those patients who pursue dialysis? I think that would just be like an interesting thing to look at, because we know that perhaps mortality is pretty similar when you get above the age of 80 with certain geriatric syndromes. Wanted to get your thoughts on that.
Yeah, that's actually an excellent thought, Dr. LeMay, because we have very small subset of patients who do choose conservative care as opposed to going on dialysis. And again, I don't think we have data on that specific subset of patient population. Although I have to admit, with the advent of the hospice care, and I have actually followed some of the veterans here at Hines who have opted for more of conservative management as opposed to going on dialysis. And, you know, there is clearly a decline that does happen. But again, a lot of the care that's provided through Hines, either as home care, hospice, end of life, palliative, I think that really adds a lot of value to the quality of life that the veteran is looking at that point in time. So I think that's a very unique subset of patient population that would be interesting to look at.
Just as a follow-up to that, so you're aware, Dr. Wadwa, we in the palliative care group nationally, we are providing what we call concurrent care, and that is when we allow patients to pursue aggressive medical care while getting hospice if our worry is that their prognosis is likely less than 6 months anyway. So we've worked really closely with oncology, and we have an entire program set up where we enroll veterans getting palliative cancer treatments who likely have a prognosis of less than 6 months to also get home hospice while they get cancer care here. And so a clinical collaborative that may expand into research initiatives with palliative care and nephrology in the future might be thinking about your frailest dialysis patients who you suspect have a life expectancy less than 6 months. They still want to go through dialysis. We will still pay for dialysis here at Hines, but we know that patients that enroll in these in home hospice tend to get to die at home, and they're less likely to pursue hospitalization at the very end of life. They're less likely to be in ICU at the end of life. It has a lot of quality of life implications for veterans, as well as financial implications for the VA system. And so thinking about concurrent care here at Hines with nephrology might be like another great idea for us to talk about in the coming months and years.
That would be absolutely wonderful and of great interest to our team.
Any further questions?
I would just like to add to my earlier comments that really would apply to all of these studies. All three projects are just really interesting, important clinical questions. Putting together the clinical folks and the research focused individuals to help us answer these questions. And I can feel some collaboration budding already across all of these teams. So congratulations to all who've received the grants, and good luck. We look forward to your success.
Thank you, Dr. Adams.
Thank you, Dr. Adams.
Thank you all to those who presented. Congratulations on being awarded as the first cohort for the Serwa scholarships and for your work. And we'll have another one of these sessions coming up. For those of you who are attending, thank you for being a part of this. And if you have any questions, please either contact me or anyone from the project team. I'd like to take a quick opportunity to thank Doctors Bill Gilmer, Bill Wolf, and Martin Gobian, who were a part of, and Dr. Holly Kramer, who have put the center itself and the leadership together. It's been really exciting and rewarding to work with them. Thank you for your work, and this video will be available on the CARES website for the Serwa Centers page. Thank you, everybody, for attending.
Thank you, Kevin.